we're going to be talking about hip and knee replacement as why it's valuable, way to do it, when should you do it, well, what can be done about it besides surgery. It's not only surgery. And then at the very end, we're going to talk about robotics, and we can answer those questions as well. So a joint is where two bones come together. It's where your elbow joint is where your upper arm and lower arm come together. A knee is where your thigh bone and your shin bone come together, and it allows us to move around. The ends of our bones are covered in a cartilage cap. And you've seen that. Take a chicken thigh, break that apart, that great cap at the end of the bone, that's what we look like. In a hip, the hip is a ball in the socket joint. That allows your shoulder, your hip to move around. Allows you to bend, walk, and sit. And it's one of our core joints in our body. The knee joint is more of a hinge joint. Bends and straightens out. There's a little bit of other motion as well. Sometimes it rotates. And these are very, very important joints for us to be able to do what we want to be able to do. Arthritis sets in when the cartilage starts to wear out. When the cartilage gets weaker. There are different kinds of arthritis. There's plain Jane osteoarthritis. There is rheumatoid arthritis, which is when your own body's immune system attacks the joint and destroys the cartilage. There's trauma. We were just talking to someone in the back. They had an ACL injury, anterior cruciate ligament injury, back in school, tore that ligament, had it reconstructed, probably had a meniscus tear, and then 20 years later, her joint went to pot. She ended up getting immune replacements. There's even infections, all different types. Whatever kind it is, the end result is pain and disability. Here's a little cartoon diagram of what a knee looks like. I made it small on purpose. Some people sometimes get freaked out. Basically, the end of the thigh bone, the top of the shin bone, and in the middle, besides the cartilage, there's something called a meniscus. Many times, my meniscus is torn. And I'm like, buddy, it's much more than that. Usually a torn meniscus is clicking, popping, and catching. And that's usually treated, this is in the younger, sporty crowd, like a football player, or these are people who are 20, 30, 40. Once you get to the 50s, it's gone beyond that. So I get that question a lot. On the bottom left of the screen, arthritis is when the cartilage wears out. The whole knee becomes inflamed. It becomes swollen, stiff, achy. You get up after you're sitting for a while like here, oh my God, the knee hurts. That's one of the symptoms of knee arthritis. The same thing can happen in the hip. Typically the cartilage wears out, the bone becomes bone on bone. And that's usually described, 80% of people describe that pain as being in the groin, right where the thigh meets the pelvis area. The other 20% of people will describe the pain elsewhere. Could be down in the knee, it could be in the lower back, a whole bunch of different areas. So that is called referred pain. Some said, oh, my thigh hurts or my knee hurts. Well, could be the head. My back hurts. Could be the head. Maybe something else. And then, of course, stiffness. That's a very common complaint. I sit down for a while, when I first get up, I'm very, very stiff. Here's a nice x-ray of what arthritis looks like. If you look at the left side, to your right, that is pretty much a normal joint. See, there's a pointer on this thing. So right over here, you can kind of see the ball and the socket. And there's space between that ball and the socket. That's cartilage, and on an x-ray, it's invisible. If you look on the left side, you can clearly see the difference. That's a severely arthritic joint. That person is walking with a limp, they're hunched over, they can't sleep, they can barely walk. So that's what an arthritic hip looks like. The knee, that's a really bad looking way. I think you can tell. That's the thigh bone coming down, and that's the shin bone coming up. And you can clearly see it's bone on one side. And this person walks with a deformed knee where their knee is knocking in. Very, very common problem. I think it's one of Medicare's biggest expenditures. Billions of dollars are spent on this problem alone. Not just on surgery, going physical therapies, injections, all these different kind of treatments. So it's a major, major, major cost center. It is the number one cause of work disability in the country. Arthritis of some joint, not necessarily the hip or the knee. Again, signs and symptoms. Do I have arthritis? Stiffness. I get up in the morning and very stiff. I get up from sitting watching a movie, I'm stiff. My knee is locking. My knee is catching. Things that used to be easy to do. I used to be able to walk, like today I saw a gentleman. They used to be able to walk 5 miles with my wife. Now, After a mile, I'm going home. So these are signs there's a problem. Can't play a sport. If you're a golfer, maybe after like 8 or 9 holes, you're done. If you're farming, difficult to get up or down in your equipment. Simple things, even sitting down in a chair, become very, very difficult. Sleep is a big problem for many people, as is the leg as well. So what do you do about it? That's what you have arthritis. First thing is make sure you have that diagnosis, that is what your problem is. Physical therapy is like the number one thing. You want to go to physical therapy to work on conditioning, strengthening your body. I'm a big advocate of that. That is awesome. People will come back after physical therapy and say, I feel great. Now, does it work all the time? No, but it works most of the time. Highly recommend that. I recommend stretching program, a mobility program. You have a Silver Secrets program where you use it. Highly recommend that. Yoga. Certainly if someone is really, has extra weight on board, that can help to lose some of that weight. Even 5 or 10 pounds makes a big difference. Did you know every time you take a step, twice your body weight hits your knee? So for example, if you weigh, let's say 100 pounds, every step I take, 200 pounds hits my knee. 200 pounds, 200 pounds. If I weigh 200 pounds, every step I take, 400 pounds is hitting my joint every step, every day. So be careful, be mindful of that. So every pound that you work on can help. Medications can always help. These medications are things like Tylenol, acetaminophen, ibuprofen, Motrin, things that you can find over the counter. Topical things can help sometimes. You've heard of Salonpas or these other brand names. The one I like is Voltaren. It's an actual cream version of Motrin that can help to buy. Voltaren gel, that's over the counter. And there are different kinds of injections that we can inject into the knee. Cortisone shots, you've heard of those. Some of you may have heard of Brewster comb or coxcomb. Those can help as well. And then there's all these other things out there. Stem cells, a PRP, these things are experimental right now, not covered by insurance, but you'll see them being offered out there. Just buyer be aware. They can't hurt you, but they may not help. It's like we talked about the medications, but medications come in side effects. Stomach upset, kidney problems. If you have a heart condition, it can aggravate that. It can increase your blood pressure, put more stress on the heart. We don't know how long you have to be on these medications. We don't know, can you take a break? Does it reverse things? So we just have to be very careful with the medications. I'm also a big believer as food is medicine. So it's very important to educate yourself on anti-inflammatory foods. These are mostly plants, fruits and vegetables. So you want to fill your plate with that kind of stuff and less of the potato chips, mashed potatoes, any kind of simple processed food. So those things can help tremendously to change a small tweak in your diet. So injections we talked about, most injections that work most of the time are cortisone shots. It's like liquid Motrin to the joint. The average duration of relief, if you're looking at a knee, about a month. I have some people get 6 months of relief, some get 3 months, and you can repeat those indefinitely. There's no limit. Some people will ask me, oh, can I only get so many injections in a lifetime? No, you can get as many as you get, as long as they work. Again, exercise, very, very important. These are a couple of my patients on the right side, getting permission to put their pictures on. The more motion you do, the better this for you. You can't make your arthritis worse by being active, but you can make it more symptomatic by being inactive. So move as much as you can, even if that means getting into a pool, whatever you can do, even share yoga, do the best you can. Motion is the lotion, right? Then when you consider surgery. So this is when you say, I can't live this way. I can't enjoy my life. I can't go see my grandkids. I can't travel. We have a trip coming up, I can't make it. Those kind of things. I can't sleep at night. I'm miserable. I've tried everything. Physical therapy, I've tried medications, I've tried injections. That's when it's time to consider. I just not quality of life is core. And keep in mind, our health is intimately connected to mobility. The more mobile we are, the more active we are, the slower we age. So that's the other thing also. So let's talk about this. So joint replacement is basically putting a metal resurfacing of your joint. We'll have some models in the back, so I encourage you at the end of the talk to head out to the back to the striker table and play around with those models and see what those are all about. It's basically a metal surface on the end of the joints for a knee. It's a metal surface on the end of the thigh bone, a metal surface top of the shin, and a piece of plastic. Common question is, how long do these things last? Contemporary knee replacements, well done, we're seeing 95% survive at 20, not to 30 years. When I started 20 years ago, we would tell people 10, 15 years tops, but that has changed a lot. So in fact, I saw someone with this recently with a 24-year-old knee perfectly functioning. It was amazing. So for many folks, the joy will outlive them. I've had a young person ask me today, she's 45, she needs a total hip. And I said, well, probably around 75, you'll be back and we'll want to take care of it. So again, the hip replacement is a ball and a socket joint. It is basically on that diagram on your right over there, that first picture I showed you, that's what that looks like. It's a stem or a metal spike that goes down into the thigh bone. That supports a ball. And on the socket side, there's a titanium or a metal socket that goes into your pelvic bone. That usually gets affixed to the bone, it grows into the bone. And in the middle, there's a ball. It's usually made of ceramic, sometimes metal. And inside that metal socket is a plastic is new cut. And the contemporary plastics now these days last such a long time. Surgical approach, if you look at the bottom there, direct anterior approach, there are different ways to do a hip replacement. I'll briefly touch on this, we can talk about it later. There are different ways to perform a hip replacement. One way that I'd recommend is the direct anterior approach. It tends to be the least traumatic, least painful, quickest recovery compared to other approaches. Long term, 6 months, 12 months, 2 years, it's the same. But that initial month or 2 or 3 months, it's a dramatic difference. I perform all the different approaches, and I see it time and time again, that approach, people recover much faster. There are some people, no matter what you do, they're going to recover great. And there are some people, no matter what you do, they're going to take a long time as well. But generally, that anterior approach is phenomenal. Big change. A knee replacement, basically a metal cap on the end of the thigh bone, a metal cap on top of the shin bone, and a piece of plastic in the middle. We generally do total knee replacements, and you can see that in the bottom of the back. Sometimes there's a partial knee replacement. Here's some x-rays. That initial x-ray I showed you earlier before, this is what that knee looks like after the operation. There's a metal cap on the end of the thigh bone, metal cap on top of the shin bone, that blank space in the middle, that's the plastic, that's the new cartilage. And not only is it straight, you can also, not only has that been replaced, you can see that the leg is now straight. That person's foot was all the way cocked out to the side, and now it's straight on me. So not only can it fix the pain, it can also restore the deformity. Here's another one, very similar, total knee replacement. You can see the metal over the entire bottom of the thigh bone, metal on top of the shin bone and the plastic. And here's a partially, so you can see only one part of the knee has been replaced. Who gets a partial? Who gets a total? Who needs a partial? Who needs a total? This is a conversation between you and your surgeon. And they'll tell you, yeah, you're a candidate for partial, you're a candidate for total. Partials are nice because it tends to be shorter surgery, faster recovery, engine. So this is a nice example. This is a patient of mine. If you look on the left side of the screen, look at his left leg right over here. This was the original video. It was too big. And you can see how it's bowed out to the side. And on the right side of the screen, that same leg, you can see he's perfectly straight. It's pretty cool every time I see that. This is about 3 months after surgery, but it's corrected immediately. Before surgery, it's not like we just run into the operating room and just get going. We make sure you're optimized, is what we call it. You're tuned up. We have you get a physical with your primary care doctor. We check a whole bunch of labs. If the person has chronic medical conditions like diabetes, we check their A1C number. If they have heart failure, we make sure that's stable. If they have chronic kidney problems, make sure the kidneys are functioning. Even do this on people who have active cancer sometimes. So we check all that stuff out, and then we say, no, this person's a reasonable candidate. These are the risks, so that when the person decides, or if you decide, because they can inform decision. The actual act of surgery itself, usually under a couple hours, hour and a half tops. It is under anesthesia, so you don't feel anything. You don't want to feel anything on this one. There are 2 kinds of anesthesia. There's a spinal, which is kind of like an epidural that a pregnant lady gets, injection in your lower back, and then you're numb from the waist down. And then during the operation, the anesthesia doctor will give you some medicine in your IV so you're sedate, take a nap. The other kind is called the general anesthesia, where you're completely asleep where you're completely anesthetized, so there's a tube breathing for you. Generally, we like the spikes. People freak out because, oh my God, am I going to get paralyzed? Am I going to have headaches? 65 years ago, I had an epidural. No. These things are done all day, every day, very, very safe. In terms of discharge, we're talking about doing surgery at the Surgery Center Cedar Rapids. These are folks that are leaving the same day. So this morning, I performed 3 operations this morning. All 3 are home already. In fact, Austin over there treated the last patient about an hour ago, and she's home now. So surgery in the morning, all day evening. All of them are able to go to the bathroom on their own, walk 25 to 50 feet on their own, stand and sit. They're all going to get in and out of their own bed tonight. They're going to get dressed, pajamas, and they're going to be able to shower. It's pretty awesome. When I started 20 years ago, 3 days in the hospital, you didn't move for like 24 hours. It was like drama. But things have completely changed over 2 decades. You have to do therapy after a surgery, especially after knee replacement. Half of the operation is physical therapy. You've got to get that knee moving. So important. Without therapy, you're really, really missing things. After a total hip replacement, the therapist will tell you, after a few visits, if you're pretty healthy, you're like, I don't know what to do with this person and one. But other people, they still need to. So physical therapy, big believer on that. Generally, you're on a walker. Some people are short walker as short as 3 days. They go to a cane. Some people are on a walker for 2 weeks, then go to a cane. But most people are additioning the cane by maybe a month. Did you folks see that therapy? Maybe a month they're off the cane tops. Driving, when can I drive? First question I get. People can drive when they feel comfortable driving. Typically after a right leg operation, which is typically the breaking leg, typically 3 to 4 weeks is the average time. For a left leg operation, typically 2 to 3. But at the same time, I've had some people drive after a week. All depends. Going back to work, for those of you that are still working, depending on the job. Today I talked to an attorney. She'll need his operation. She works from home. She'll be back to work within a couple of days on the computer. My patients who are carpenters or plumbers, 6 weeks minimum, maybe 8. They're on their feet, hands and feet all the time. So it all depends. So these are folks that, these are all of my patients. This gentleman went up to Canada fishing within like 3 months after his hip replacement. The guy in the middle, the man he works for the wine company. Both of his hips are replaced. Super happy. That gentleman far right, he's currently walking, I think, like 3 miles, like a month and a half after his operation. This is a lady 2 weeks after the replacement. That's 2 weeks. So I show these videos so you can see, but it's not that scary and not that bad. So she's a success story in there. Okay, we'll get to the very end, then we'll go to the questions right here. So one way that we can implant for these operations is using technology. I'm a big believer in technology. Like Kelly mentioned, I was in engineering school. I worked for a little engineer. I like numbers. And so the platform that I use is what's called the Mako platform. And as we can see, it's kind of like this robotic, it's this tool attached to an arm. And basically what it does, it allows us to perform the operation in a less traumatic, less invasive, gentler kind of way. Basically what happens is take a 3D scan of your hip or your knee, and on the computer, we actually design the operation and perform the operation on the computer first, see exactly how this should work, what sizes things are supposed to be, how they're supposed to be performed, how the cuts are made before we even start. So we already have an idea what's going to happen. So you remember those x-rays I showed you before? Instead of just looking at an x-ray and then on performing the operation on that x-ray, before we get started, we actually have these 3D models that you can see here on the screen. We can get an idea what size is this person's knee, what are the technical things we look at, angles, the amount of bone that needs to be removed before we even get started. So before we get started, we already have an idea of what's going to happen with the operation. Very, very neat. This is very, very cool. It's been around for a long time, since 2009 even. I've been doing this, using this technology since 2017. And we're excited that we have it here in town. So not every place has this technology. In Surgery Center Cedar Rapids, we have it. In the surgery at PCI, we're using this technology. Very advanced, very cutting edge. So the reason I like it, it's precise, it's accurate, it's reproducible, customizable, And if used correctly, less traumatic, so you have less pain, you recover faster. And there's some data to support that. So again, like I showed you the pictures before, joint replacement is awesome. You get your life back. Your pain goes away mostly. You're able to do the things you want to do, participate in life with your family, and just go on with your life and move on. They take care of other things. You're not stuck with this joint. Thank you. What are my limitations after my operation? None. Zero. You can walk, run, golf, ski, lift, climb, hike, whatever.
Can you kneel?
You can kneel on these. In my experience, most people don't like to kneel on the knees. It just feels funny, it feels weird. To be very, very clear, I listened to a podcast recently with 4 orthopedic surgeons with this specific question about sports after joint replacement. They're all over the place. So I let my patients do this, I don't let them do this. I have patients running on these joints and they're fine. But, right? So then really I'll get to you. There's no restrictions on this. It's just more what feels right and range. Is an arthritic joint like rust forming on metal? It's more like a brake pad wearing out. I put it that way. Brake pad, your brakes. The pad is wearing out, and now your brakes being pressed up. It's more like that. There's a shim that's thinning out. I would say that's a better analogy than this. Great question. You said you can get as many cortisone shots as you want. There's no limit, and will Medicare pay for it? Yes. Cortisone shots generally in our practice every 3 months, and most orthopedic surgeons do them every 3 months, 12 weeks. There are some every 6 weeks, but that's general consensus. It's safe to do that. As long as they're effective, absolutely. So the other question is, what about Synvisc? Synvisc is a brand name of one of those gel injections we talked about, cotton comb, rooster comb, gel injections. That's all the same term. Synvisc is the brand name of one, but different kinds. There's Uflexa, Suparts, all this stuff. The gel injections, if you want the honest truth, the modern data says it's not making better than cortisone. Okay. That's the contemporary data. But some patients say this made me feel better. And some said it makes no difference. But if you look at all the evidence in the setting of an arthritic knee, has been shown to be different. Now, does Medicare pay for them or insurance pay for them? Before we even do those injections, we get authorization from the insurance company. We find out. So if a person's copay is like $800 for that shot, I would tell a patient, don't do it. But if their copay is $5, $10, can you try cortisone? Yeah. Yep. It all depends on which insurance, and then if it's a Medicare, which Medicare plan. If it's non-Medicare, which Medicare plan. So we always check the numbers. So it's not like you're going to get a surprise bill. And how long? Is there any waiting time between the shot and surgery? Yes. The general consensus is 3 months waiting time between joint injection and surgery. That's so you reduce the risk of getting an infection. That's the complication that we are the most concerned about. So generally 3 months between a shot and surgery. That's the general study. So the question is, I'm getting an injection 3 weeks before surgery, it deadens the nerve. We'll stop that, full stop. That's not an injection. What you're getting is you're having an injection into a nerve, not the joint. It's called the geniculate nerve.
Where is the nerve at in the knee area?
There are a bunch of different nerves that basically envelop the knee called the geniculate nerves. We heard that term in the shop. There's, I think, 4 of them, I think. That's their job. They'll do that part of the knee. They just surround the knee. And there's some data that procedure can reduce your discomfort after the operation. Something like that. So again, very, very specific here. So the kind of, if you're getting a nerve deadening, that could be called a geniculate nerve block. Then what you're talking about is you freeze the nerves before surgery. There's a procedure there called IFL. There's some evidence that could help with your pain after the operation. But we offer that here in town as well. Right. So it's not for everyone, but sometimes it can help, sometimes it doesn't. That's different. We're talking about injections into the joint. You have to wait for surgery. These are injections into the nerves and the skin. Yeah, these are outside the joint, so completely safe. Okay. Yeah. What is pain like right after surgery?
Oh,
Okay. Yeah. So knees hurt a lot. Not gonna sugarcoat it. Hurts a lot. Sometimes the person's arthritis is so bad that when they come in at 2 weeks, they're not taking any more pain medication. I just saw a gentleman today. That's unusual. But right after the operation, quite a bit of pain. So what we do to help you, the following. Number one is that spinal we talked about. That lasts only about 4 hours or so, 3 hours, 2 hours, 1 hour. Right before the operation, we're talking about knees. Here in town, and most places around the country, you get what's called a nerve block. We inject medicine into the thigh right before the operation. That numbs up the front of the leg for about 18 hours. So that's number one. On top of that, everyone gets a package of medications. There's an anti-inflammatory, usually that's the family of Motrin, high levels of Tylenol, usually aspirin of some type as your blood thinner, and then usually some kind of opioid, narcotic, oxycodone, hydrocodone. You've heard of these kind of things. That's called multimodal pain control. When I started 20 years ago, you just got one drug. That's it. Suck it up, buttercup. That's it. Get out. But now we've learned over the years that that's cruel. So instead of these very high levels of this one medication, much lower levels of these 4 or 5 medications, and then take it in combination, it can help. Rapid mobilization, we used to hold people in bed for 24 hours at the joint place. Some of you may remember, you've been around long enough. That was very painful, and we learned, oops, we get them up quickly. So for pain after the operation, it hurts a lot. We put you on pain medication. During the operation, you're getting pain medication. As soon as you come out, we start loading you with these medications so that when all the anesthesia wears off, you already have pain. And that's so important that you're being happy. Did I answer that appropriately? For a hip, not so much. Hip not necessarily as painful as the knee. In fact, that first 24 hours, you're feeling great after a hip. 36 hours, you're like, oh my gosh, what is this? And then 40, 72 hours after a hip, though. Okay, I can handle this. So hips tend to be much more serious than others. Okay, the question is, am I too having to have surgery? You know, am I going to be told to wait? The answer, first of all, when it comes to a referral, depends on your insurance. I mean, yeah, and if you have plain Jane Medicare, I think you can just call that occasion. But you can call the office to find out your minimum for a thing. So when it comes to weight, this is a touchy subject, not just for patients, but also for us. This is my opinion, by Disney. It depends on the distribution of the weight. Many men carry their weight from the waist up. 300 pounds from the waist up, and their legs look like mine. That's different compared to someone who's 300 pounds and is all below the waist, and their legs are, like that. So it becomes technically very difficult to perform the operation in that second case. The other reason we watch weight closely is it's not the weight as much as sometimes it's a marker of a person's health. If a person is 400 pounds, 500 pounds, and I have patients like that, generally there's a whole bunch of medical problems in that person as well. Uncontrolled diabetes, heart failure, kidney problems, and so on and so on and so on. That places them at such a high risk of a complication that we're going to make them worse. So it's not like you're heavy, get out. It's not like that. There's a whole thought process behind it. So the answer is it's a more nuanced answer. If it's just the weight, it depends on what the body, where the weight is. So that it's not just a simple yes or no. You have to be this BMI. How many of you have heard of BMI? Yeah, that's right. It's not just that. It's more nuanced. So Erica suggests you make an appointment, have that conversation, and then go and bring it out. Say, hey, will you bet? Do you still need to take antibiotics when you go to the dentist after a joint replacement? The official American Dental Association recommendations and American Academy of Orthopedic recommendation. They got together. All the smartest orthopedic surgeons and the smartest dentists in the world got together at a big meeting and put out a paper. The short answer is probably not. Yeah, probably not. So for routine cleaning, for joint replacement, if you're pretty healthy and no major medical problems, you don't have to. That's the official recommendations. However, if it's more than that, a root canal, you get a tooth extracted, you've got these pockets, you've got blah, 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 you probably shouldn't take some antibiotics. If a person has uncontrolled diabetes, they're very sick, they should probably take an antibiotic. So the thinking is this: the human mouth is full of bad, really bad bacteria, like super bad, dangerous bad. If that bacteria breaks into the bloodstream, like a tear in gum in your mouth, like a moth to a flame, it can travel to the joint. It's an artificial device, it can get infected. You may have heard of people get heart valves infected, that happens a lot, and that's how that can happen, the same process. So the idea is we don't want you to get that joint infecting. So the answer is the official recommendations, but a healthy person for a routine thing, probably not. But the different surgeons, different dentists will recommend different things, and it's all over the place because it was so afraid of infection. It's starting. What is arthritis? Can you catch it? Is it contagious? What exactly is it? Arthritis is an umbrella term that means painful joint. Any itis is inflammation. Sinusitis, this itis, that itis. It means it's an inflamed joint. How you get an inflamed joint, there are different causes. Trauma, we talked about someone tore their ligament in college from football, and that led to abnormal wear and tear in the knee, abnormal forces in the knee, and they ended up with a knee replacement. To keep it simple, it's when the cartilage or when the padding has worn thin. How does that happen? It could be from trauma. It could be from overall chronic inflammation. We think plain Jane osteoarthritis may be similar to like heart disease. How do people get heart disease? Chronic inflammation, chronic deposits in the vessels. We think it's the same thing in the joint. Chronic underlying long-term inflammation. How does that happen? We're not sure. But it's when the end stage is when the cartilage goes away, the bone touches the bone, the other parts of the joint get inflamed, the lining of the joint gets inflamed, they send off these pain signals and the brain experiences it as pain. It's not a great answer, kind of a vague answer, but it's not contagious. Is it hereditary? We think there's a hereditary component, we just don't know what percent. Oh, my mom and my dad had this done. I don't know if that means you're going to get it. We don't know that. We don't know that part. Who? Great question. Who is not a candidate for same-day surgery? So we have a criteria, we have a list. There's an actual checklist we have. Is this person, there are certain things you cannot have. Heart failure. No way. Just had a heart attack 2 weeks ago. Well, you're not getting surgery anyway, but no. So there are hard stops. And to the question about weight, we do have a weight limit at the surgery center. By person, whatever that number is, there's a certain number. So who is a candidate? These are generally people who are active, mobile, whatever chronic conditions they have, like blood pressure, diabetes, very well controlled. So a person who can get up and walk around, they have great support at home. That's the most important factor. They have support at home. For example, they have someone that could take the therapy, take the calls. Weight is a factor, chronic health conditions are a factor, and then motivation. Typical, for some reason, think a hospital is a hotel, right, Laura? Yeah. I'm going to stay 3 nights. And then other people like, I want to get home as soon as possible. So motivation is a factor. So we have a criteria in the list, but generally, when you meet with your surgeon, if that time comes to make a decision for surgery, you would say, hey, am I candidate for same-day discharge? Can I get done at the surgery center? Do I have to be done at the hospital? Hospital are for people who have these major medical problems. heart disease, uncontrolled diabetes, this, that, the other. No one at home. There's some people by themselves. Yeah, basically. I live at home alone. I have no one with me. I need to get my hip replaced. What do I do? So there are different options. Option one is maybe you find a way. You have to be with someone. We can't send you home alone the same day. That's not going to happen. How long do you have to have someone there? So find someone, whether it's a adult child that lives nearby, you can stay with them, a really good friend, a sibling, a parent. So after a hip replacement, you're pretty much independent. They're just babysitting. They're just watching you. What do you need, honey? Want a glass of water? I'll get that for you. That's what it is. They're not bathing you, dressing you, just watching you. How long do you have to be? There's no hard and fast rule that I'm aware of. 72 hours. There you go. 72 hours. There you go. 72 hours. I think that's reasonable.